Hi everyone, welcome back to NExT Level Ophthalmology. Today we'll be continuing our class on uveitis and we'll deal only with anterior uveitis today. Anterior uveitis is defined as inflammation of the iris and or the ciliary body. It's usually a combination of both, and most common type of uveitis that is encountered in the clinical practice. So anterior uveitis is something that you see day in and day out. Okay, it can be granulomatous or non-granulomatous as we discussed in the previous class. So what are the causes? Let's consider the non-granulomatous causes for anterior uveitis. So acute causes are post-traumatic and post-operative, which we see more commonly. Tuberculosis, then HLA-B27 associated uveitis, which can be due to some systemic disorders like ankylosing spondylosis, which is characterized by low backache, sacroiliitis, acute recurrent unilateral iridocyclitis. Okay. Ritter syndrome is a non-specific urethritis with arthritis with conjunctivitis plus or minus uveitis. Psoriatic arthritis, which is characterized by psoriasis, psoriatic arthropathy, nail changes, and non-granulomatous iridocyclitis. And then you have the inflammatory bowel disease associated uveitis. And then we have the tubulointerstitial nephritis associated with uveitis known as TINO. So these are the acute causes of non-granulomatous anterior uveitis. The chronic causes are juvenile idiopathic arthritis, which is characterized by the famous Still's triad. It's a triad composition of fever, joint pain, and characteristic rash. Then there is Fuchs heterochromic iridocyclitis or Fuchs uveitis syndrome, which is a very specific type of uveitis. So what are the granulomatous types? Tuberculosis, sarcoid, leprosy, syphilis. In leprosy, we get small granulomas called lepra pearls on the iris. In syphilis, we get iris roseola, which is dilated iris vessels and granulomatous iridocyclitis. It can also have interstitial keratitis with non-granulomatous uveitis in congenital syphilis. And then there is viral iridocyclitis or viral anterior uveitis, which is characterized by sectoral iris atrophy, stellate diffuse KPs, raise in the intraocular pressure, also called as ocular hypertension, and candy cane hypopia. So these are the specific causes of granulomatous anterior uveitis. There are some drugs also that cause anterior uveitis. So the systemic drugs that are associated with anterior uveitis, let us remember it as BRICS, bisphosphonates, rifabutin, cidofovir, and sulfonamides. Okay, there are some topical drugs that are associated with uveitis. One is metoprolol, brimonidine, and prostaglandin analogs. So out of these two are anti-glaucoma medications which are known to cause uveitis. Okay. So clinical features of anterior uveitis, they present with brow ache. It can be unilateral or bilateral. Photophobia is very characteristic of anterior uveitis. That is due to the irritation of the ciliary nerves. Then there is ciliary congestion present with redness and decreased vision. So on what are the signs? In the cornea, you can have circumcorneal or ciliary congestion. Ciliary tenderness, it is a sign that is elicited by gently pressing over the ciliary zone area through the lids. The patient will wince. So next is keratic precipitates. These are fine cells that get deposited on the endothelium of the cornea. It can be fine KPs or mutton fat KPs, corneal edema, and band-shaped keratopathy in late stages. In the anterior chamber, you can see cells, flare, and hypopyon, which are used to describe the activity or the grade of inflammation of the anterior uveitis. The iris becomes muddy and it looks edematous. Queppe nodules, Busaka nodules, these are the specific type of nodules that are commonly seen in granulomatous anterior uveitis. Festune pupil due to formation of posterior synechiae. Ectropion uvea when the posterior part of the iris is everted and it is shown on the anterior surface. Seclusio pupillae when there are posterior synechiae throughout the circumference of the pupil. Then in the lens, you can see pigments on the anterior lens capsule. You can see a membrane and a posterior subcapsular cataract, also referred to as a complicated cataract. In vitreous, you can see some spillover anterior cells from the anterior chamber. So vitritis and cyclitic membrane. Retina, you can have cystoid macular edema when the inflammation is severe in the anterior chamber. IOP related changes, usually it is low due to inflammation of the ciliary body. There are a very few conditions when you get hypertensive uveitis, in the sense the IOP is high, which is characteristically seen in Fuchs uveitis syndrome, juvenile idiopathic arthritis and viral anterior uveitis. When the uveitis becomes very chronic, there is ciliary body shutdown leading to thusical eye. So these are non-granulomatous versus granulomatous keratic precipitates. If you see, the size is much bigger, and if you see on the slit lamp, they have a volume. So these granulomatous keratic precipitates are nothing but tiny granulomas that get deposited on the endothelium. So there is a characteristic pattern in which these KPs form. So why do they get attached to the endothelium? Because in anterior uveitis, there is some amount of endothelial dysfunction and the endothelium of the cornea gets sticky. And due to inflammation, there is outpouring of these WBCs into the anterior chamber, which then get attached to the back of the cornea. So if you see in non-granulomatous conditions, if you see the keratic precipitates, these are nothing but lymphocytes, whereas here if you see in granulomatous, you might find epithelioid cells and macrophages. Okay. So why do they get deposited? See, if you see, the upper part of the cornea is relatively clear of the keratic precipitates, whereas it's more common in this triangle. So this triangle is known as the Arlt's triangle. So what happens is, due to the convectional currents within the anterior chamber, these cells get deposited in the inferior part of the back of the cornea. So they are more commonly seen in the inferior part of the cornea with a triangle apex upwards and base downwards. Okay. Then there is ciliary congestion of the ciliary vessels here, if you can see, and band-shaped keratopathy on long-standing cases. So how do cells and flare appear? Cells are these minute dots that you see that are seen floating within the anterior chamber. It is seen by making a small beam of 1 mm by 1 mm in high magnification and maximum brightness in a slit lamp. So you have to count the number of cells and grade them accordingly. So this smoky appearance, like if you can see this smoky appearance of the anterior chamber, so that is a measure of flare. So the activity can be measured by cells and flare. And this is nothing but a festoon pupil. If you can see, these are the places where the iris has got attached to the anterior lens capsule. So when you dilate the pupil, the rest of the pupil will dilate excepting these areas. So you get a amoeboid shaped pupil, and this is known as a festooned pupil, Festooned. So what are the causes of decreased vision in iridocyclitis or anterior uveitis? There is some amount of corneal edema. Sometimes you might have large greasy KPs that can blur the vision. Presence of a plasmoid aqueous or aqueous flare. Small pupil exudates blocking the pupil or covering the lens capsule, and more commonly and significantly a complicated cataract. So these are the causes of decreased vision in iridocyclitis. I would like to add cystoid macular edema as well, which can contribute to visual loss in iridocyclitis. Let's take a question now. A 26-year-old patient complains of redness in his right eye for 4 days, which is associated with pain around the eye and photophobia. So very characteristic features of anterior uveitis. And acute anterior uveitis, the duration is less than 3 months. So this is just 4 days of duration. So this is certainly acute, and there is photophobia and brow ache. On examination, there is ciliary congestion and ciliary tenderness. Okay, both are characteristic of anterior uveitis. So choose the points in examination that favor a diagnosis of acute iridocyclitis. Fine keratic precipitates, true. Anterior chamber cells, yes. Anterior chamber flare, yes. Cataract, it can result from anterior uveitis, but it is not specific. So just because there is a cataract, you cannot say there is iridocyclitis. Band-shaped keratopathy can result from many conditions that has caused chronic inflammation. So it is not a sign of acute iridocyclitis. So the right answers are A, B and C. In a hypothetical patient with iridocyclitis, the KPs were seen under an electron microscope and revealed to be made of epithelioid cells and macrophages. Which of the following is true about this case? So we just discussed this. This is the histopathology of KPs. See, please remember it's a hypothetical case. We do not require examination of KPs under electron microscope in case of any anterior uveitis. It is really not required. With the slit lamp examination, we can classify them as non-granulomatous or granulomatous. So the options are, we are dealing with the case of non-granulomatous uveitis. This is wrong because we are dealing with the granulomatous inflammation. This patient needs to be investigated for tuberculosis, correct? Because tuberculosis is the most common cause of granulomatous anterior uveitis in India. The inflammation associated is usually severe and aqueous plasmoid. Let's go back to our class and remember that granulomatous inflammation is usually a slow and chronic inflammation. So this is wrong. The KPs tend to be small and scattered all over the cornea. No, see, mutton fat KPs are usually large and ladiaceous and seen more in the inferior aspect of the cornea within the arch triangle. So the right answer here is B. Which of the following does not favor a diagnosis of phthisis bulbi? So phthisis means shrinkage. So this was referred to TB in the past when the patient would lose all his weight and get emaciated. So phthisis bulbi, bulbous means eyeball. The eyeball becomes shrunken. So it is an end stage of any chronic uveitis. So shrunken eye, yes. Soft eye, yes, because the ciliary body shut down. Vascularized cornea, yes. Presence of perception of light, wrong. So in a phthysical eye, the vision is usually lost. So let us remember 4S: sightless, sunken, soft, and shapeless. Because there is no turgor within the eyeball, the eyeball gets a quadrilateral shape because of the muscles, the four recti muscles that are pulling the eyeball. So the four S's that describe a phthysical eye. There is absence of perception of light, PL negative. The right answer here is D. So this is how a bicycle eye looks on CT scan. If you can see, there are calcifications within the eye. The eyeball is shrunken. So the stages of phthisis are, in stage 1, also known as atrophic bulbi. The eye is atrophic. The eyeball retains its shape, but there is no sight. The lens is cataractous and there might be a retinal detachment, but the IOP is somehow maintained due to the inflammation that is ongoing. Okay. In stage 2, corneal vascularization and edema start developing. In stage 3, there is calcification in the Bowman's membrane of cornea. This is known as band-shaped keratopathy, BSK, retinal pigment epithelium and the lens. So intraocular ossification is almost seen in all tissues of the eye. There is no intraocular pressure. The eye appears quadrilateral due to the pull of the recti muscle. So stage 3 is the end stage of phthisis. So which of the following is false about cells and flare? Cells and flare are a sign of activity in the eye. Flare is explained by the Tyndall effect, right? Tyndall effect is seen when there is a turbid medium and you see particles within the medium going here and there. So this is known as a Tyndall effect in physics. It is measured by making an oblique beam 1 by 1 mm under high magnification, true. So we have to find the false. So let's write true. Cells appear before flare appears and disappears after flare appears. This is false. The flare is always first to appear and last to disappear. Can be measured objectively by laser flare photometry. Yes, this is a new tool that is coming up and in which you can objectively measure flare, because subjectively when me and you measure flare, it might be different. So the right answer here is C. Let us learn about cells and flares. So the first image here shows the Tyndall effect, in which in a dusty room, if there is a sunlight entering, you can see the rays, the beam of light rays like this. So in the high magnification in a slit lamp, this is an excellent picture I got from the net. So these dots here represent the cells or the WBCs that are floating within the aqueous, and the smoky appearance is the flare. So this is characteristic of iridocyclitis. So how do you grade them? We count these cells in this 1 by 1 mm, and approximately, depending on the number of cells, we grade them. So this grading helps you know the intensity of inflammation. Also it helps to follow up. Suppose today the patient is 3 plus and tomorrow it's 1 plus after adding steroids, then you know he's doing better. Then how do you grade flare? So grade 1 is faint, grade 2 is moderate when the iris and the lens details are still clear. Grade 3 is marked when the iris and the lens details are hazy, but you know you can actually see the iris in the lens. So 4 plus is whenever there is a fibrin or plasmoid aqueous and the details are very bad. So what are the following? Match the following types of keratic precipitates. Fine KPs, we know that it's seen in acute uveitis. Or crenated KPs are a sign of old uveitis in which they shrink and the edges become crenated. Stellate KPs, don't think they are star shaped, no. Stellate is like in a night sky when how the stars are scattered throughout the sky. So there are KPs throughout the cornea, not just in the arch triangle. So this is very characteristically seen in herpetic uveitis. And mutton fat KPs are seen in granulomatous uveitis. So let's take our answer. A4 and B1, yes, looks like C. And C2, yes, and D3. Alright, so the right answer here is C. So these are the different type of KPs. So I would like you to remember, fine KPs, non-pigmented KPs are fresh. They are seen in non-granulomatous anterior uveitis. Crenated KPs suggest old KPs. They also become pigmented. Stellate KPs are seen in herpetic uveitis and also in Fuchs uveitis syndrome. These are conditions with low-grade inflammation, and I explain why they are stellate. Marten fat KPs are seen characteristically in granulomatous conditions. So now if you see the arrows here, we know that iris has a lot of blood vessels and cornea is the cooler part, right? Because there are no blood vessels in the cornea. This is cooler and this is warmer, okay? So what happens by normal conventional currents, whenever there is anything hot, things go up like air and water. So aqueous, which is majorly containing water, it moves up when in contact with the posterior aspect of the anterior chamber. But when it comes here, the current goes downward because of the temperature being lesser. So this is the normal way in which the aqueous current moves. So what happens when there are cells here floating? Because of the current, they all gravitate downwards along the conventional currents and get deposited in the lower part of the cornea. So what happens when the inflammation is very intense? There is lot of blood entering the iris, right? So the temperature is too much. So you have lot of temperature difference between the anterior and the posterior, which is more than normal, and thus you get an arch triangle distribution of the KPs. But that doesn't happen in Fuchs uveitis syndrome because it's a very mild grade inflammation. So you get KPs that are deposited everywhere else in the cornea. Okay. A 46-year-old male patient walks into your OPD with a slouching back and complains of recurrent episodes of red eye and pain around his right eye since last summer. On examination, there is mild ciliary congestion and tenderness. There is anterior chamber 2 plus cells and flare 1 plus. The fundus is normal. So this is a straightforward case of ankylosing spondylosis. So one thing that is missing here is the history of inflammatory back pain. Inflammatory back pain is characterized by joint stiffness lasting for more than 30 minutes in the morning and which improves with exercise. Okay. So this patient here typically has a slouching back, which is suggesting of a bamboo spine, and we know that HLA-B27 associated uveitis is recurrent and tends to be unilateral. It can have alternating presentation, once left eye, once right eye, and the next again it can have a right eye. So on examination, there are features suggestive of anterior uveitis. So pick the right statement. We are looking for a B27, not a B51. So this is false. Topical steroids are sufficient, again false. We need intense cycloplegia in these cases, and especially we continue the cycloplegics even after stopping the steroids to prevent recurrences. Imaging of the spine shows bamboo spine deformity true. The spine shows fixed extension deformity, so it's a fixed flexion deformity that you see. So the right answer here is C. So this is how fusion of the bones lead to a bamboo spine or a fusion deformity. There are other specific types of anterior uveitis I want you to know. The first one is Fuchs heterochromic cyclitis or Fuchs uveitis syndrome, that is more commonly called now. There is mild grade inflammation of the pars plicatum. Okay, so it's not pars splenitis, it's pars plicatum or the anterior portion of the ciliary body. So the keratic precipitates, there are stellate and they may be the only sign of inflammation. There is absolutely no cells or flare or congestion. So it's a white eye with only KP. So what is the problem here? There might be loss of pigmentation of the iris leading to heterochromia, so much so that each eye looks of a different color. The patient will develop complicated cataract as the inflammation is chronic, and secondary glaucoma also can develop. There is absence of conspicuous absence of posterior synechiae that is characteristic of FUS. Okay, so Amsler sinus because of small new vessels that develop within the angle. You can have fine filiform hemorrhages while performing paracentesis during cataract surgery. Okay, treatment, you don't need to treat it aggressively as the grade of inflammation is very mild, and long term you have to rule out glaucoma in these patients and treat glaucoma. Whenever there are acute exacerbations, you treat with topical steroids. Now coming to another peculiar form of anterior uveitis, Posner-Schlossman syndrome, also known as PSS or glaucomato-cyclitic crisis. Okay, and there is glaucoma and cyclitis both, and why we call it crisis? Because there is a spike of IOP. Okay, there are recurrent attacks of unilateral eye pain, and there is mild anterior uveitis associated with very high IOP. So the IOP is usually low in anterior uveitis, but in this case there is high IOP. Probable cause, it may be rubella virus or CMV virus or H. pylori infection causing inflammation of the trabecular meshwork, also known as trabeculitis. It's usually seen in young males, and they typically present with colored halos due to sudden onset corneal edema. So this is an open angle glaucoma, not an angle closure disease. And slit lamp examination will show a few KPs and cells and corneal edema and a very high IOP. So we have to use topical steroids and anti-glaucoma medications to tide over these acute episodes. So let's take a question at this point. A 35-year-old patient comes with mild blurring of vision in the right eye. He was referred by a general practitioner with a suspicion of cataract. On slit lamp examination, there are small KPs throughout the cornea and there is a posterior subcapsular cataract with trans-illumination defects in the iris of the involved eye. So there is some amount of heterochromia and few KPs, no cells, and a subcapsular cataract. So what are we looking at? We are again looking at a Fuchs uveitis syndrome. Okay. So what is the false thing? You have to pick the false statement here. We are mostly dealing with Posner-Schlossman syndrome. No, we are dealing with the Fuchs syndrome. Intraocular pressure needs to be checked carefully. Yes, we have to rule out glaucoma. There is a probability of bleeding into the anterior chamber. Amsler sign, yes, true. Posterior synechiae uncommon in this condition, true. So the right answer here is A. We are dealing with the Fuchs heterochromic iridocyclitis. The most common cause of uveitis in childhood in the Western countries is, so in India, again the most common cause of uveitis in childhood is TB, but in the Western countries it is juvenile idiopathic arthritis. An 8-year-old girl comes with NA positive, RF negative juvenile idiopathic oligoarthritis and has been referred to you for ruling out uveitis. So there are many clues in this question. It's a girl child, it's an RF negative, ANA positive, oligoarthritis. So these are all features of arthritis in a pediatric age group that favor uveitis. So uveitis is common in girls, especially if they have ANA positive and RF negative, and if they have an oligoarthritis involvement. So how do these patients present? They present with bilateral non-granulomatous anterior uveitis. Okay, the eye is usually not red, but there might be intense activity in the form of cells and flare. The patients may not present to you with pain. They might present with glaucoma. They might present with chronic uveitis, causing band-shaped keratopathy and loss of vision. So the right answer here is bilateral non-granulomatous anterior uveitis. So this question is about the management of JIA associated uveitis. So we have to find the management of GI associated uveitis differs from a typical iridocyclitis in an adult in all of the following except atropine is the preferred drug. Atropine is the preferred drug in adults but not in GIA. Okay, because GIA is usually seen in children, and then when you dilate the pupil with atropine, there is a high chance of developing amblyopia. One. Second, because there is a propensity to develop posterior synechiae more often, you might cause posterior synechiae in the fixed dilated pupil. So what you need to do is you need to give them a cycloplegic that allows the movement of the iris. So you can give a homatropin or a tropicamide. Some people prefer weekly homatropin so that you keep the pupil mobile. Okay. Examination is mandated even if the child is asymptomatic. So this is also true. Glaucoma is more common. So methotrexate is the first line of drug. So actually we don't need immunosuppressants like this in case of typical iridocyclitis in adults, but in children methotrexate is needed and it's the first line of drug. So atropine is not the preferred drug. So that is the right answer here. So how do you investigate anterior uveitis? So uveitis, most common causes idiopathic, is an old school of thought. Now we know that all cases, if they follow a particular pattern, we need to investigate in accordingly. Okay. So recurrent iridocyclitis, especially if it's bilateral, you have to aggressively investigate them. Other investigations like B-scan, FFA, autofluorescence, and indocyanine green angiography and ultrasound biomicroscopy might be helpful. So if it is a non-granulomatous recurrent anterior uveitis in an adult, what are the investigations you will do? We discussed all this. HLA-B27, chest X-ray to rule out tuberculosis, VDRL and FTA-ABS to rule out syphilis. So syphilis is back in the society now. It's gaining its momentum. If it's a granulomatous anterior uveitis, again you have to rule out TB, sarcoid and syphilis. If it's a granulomatous anterior uveitis in a child or in an adult with a suspicion of sarcoidosis, like if there are tented synechiae or if there is a dry eye, you want to rule out sarcoid, then you have to do an HRCT or whole body gallium scan. If it's an anterior uveitis in a child, again ANA, HLA-B27. So which of the following is true about investigations in tuberculous uveitis? So tuberculosis is the most common cause of uveitis in India. A positive Mantoux test has no value in diagnosis. Of course it has a value. So this is false. Can have manifestations in the anterior and posterior segment too. Okay, tuberculosis has a lot of manifestations. It can cause anterior uveitis, it can cause intermediate uveitis, it can cause posterior uveitis, it can cause pan uveitis. So it can cause any type of uveitis, and quantiferon is positive only in active tuberculosis, again false. It fails to differentiate between latent and active TB. It just says there was TB. Quantiferon. Quantiferon is uh, interferon gamma release assay. It measures the amount of interferon gamma that is released from the WBCs when there is an infection with tuberculosis. So always presents as granulomatous uveitis? No, again false. It can present, most of the time it presents as a granulomatous uveitis, but again it can present as non-granulomatous uveitis. So the right answer here is B. So how do we treat anterior uveitis? Cycloplegics and mydriatics, most commonly homatropin and atropine. Steroids in the form of dexamethasone or prednisolone is used depending on the severity of inflammation. And when do you need to give subconjunctival midricane? Midricane is a cocktail of adrenaline, atropine, and procaine. It's used to break posterior synechiae when topical cycloplegics are not working. So, how does atropine help in uveitis? This is the favorite question of teachers. It relaxes the ciliary muscle and improves the symptoms of pain. It reduces exudation and decreases hyperemia. It keeps the pupil dilated and helps the breakage of synechiae. It disrupts pupillary block. It increases blood flow anterior chamber, and it relieves the pressure on the anterior ciliary vessels. It increases drugs absorption, other drugs being absorbed better, and it has an anodyne effect. Okay, so these are the uses of atropine in uveitis. A 40-year-old male presents with unilateral red eye associated with brow ache. On examination, there are fine capes in the inferior part of cornea. Anterior chamber shows 2 plus cells in flare. There is 1 mm hypopyon. Which of the following is not useful in the treatment of this patient? So, this is clearly a case of acute non-granulomatous anterior uveitis. So, prednisolone is of course useful. Dexamethasone is also useful. Topical atropine, of course. Proparacaine is of no use. So, proparacaine is a surface anesthetic and has no value in anterior uveitis. So, that's all for today. We'll meet next week with intermediate uveitis. Thank you. I hope you learned well.